Hello everyone, good evening. Welcome back to our YouTube channel. This is the Drug of the Day series where today we'll be discussing briefly about the drug enalapril. So let's get started. So enalapril belongs to the class of antihypertensive agents. We know what are antihypertensive drugs. These are the drugs that reduce blood pressure, and its subclass is ACE inhibitors. So in antihypertensive class, we have many categories, one of which is ACE inhibitors. We'll see the classification later on. And the main use of enalapril is in the treatment of hypertension, obviously, because it is an antihypertensive drug. It is also used for heart-related problems like MI, that is myocardial infarction, CHF, that is congestive heart failure, and also other cardiovascular risks. Now, this is the flowchart which I took from KDT. Now, this flowchart is the regulation of electrolyte balance, plasma volume, and blood pressure by the renin-angiotensin system. So, as you can see here, this renin-angiotensin system is a hormonal system that plays a very important role in controlling the water excretion, sodium excretion, and also our blood pressure and body fluid volume. So the precursor of angiotensin, that is this angiotensinogen, this gets converted into angiotensin 1 with the help of renin. This renin is secreted by the JG cells, which are the juxtaglomerular cells of the kidney. So angiotensinogen, which is the precursor of angiotensin, in the presence of renin, which is secreted by the JG cells, gets converted into angiotensin 1, which is a decapeptide. Now, this angiotensin 1, in the presence of converting enzyme, this converting enzyme is actually angiotensin converting enzyme, that is ACE, that is also known as kininase 2. This angiotensin 1, in the presence of ACE or kininase 2, gets converted into angiotensin 2, which is an octapeptide. So angiotensin 1 was a decapeptide and angiotensin 2 is an octapeptide. So this is very important. You need to remember the number of peptide molecules each angiotensin is made up of. Then this angiotensin 2, in the presence of aminopeptidase, gets converted first into angiotensin 3, which is a heptapeptide, and then into angiotensin 4, which is a hexapeptide. And then finally, these angiotensin 3 and angiotensin 4 gets converted into inactive fragments in the presence of non-specific peptidase, which are known as angiotensinase. Okay, so angiotensinogen, that is secreted by the liver. Yes, I forgot to mention this. Angiotensinogen is secreted by the liver. It is also synthesized and secreted by the liver. Then it is brought into the circulatory system where it gets acted on by renin, that is secreted by the JG cells of kidney. Then this gets converted into angiotensin 1. Then this, in the presence of ACE or kininase 2, gets converted into angiotensin 2. Then this, in the presence of aminopeptidase, gets converted into angiotensin 3 and 4, and finally into inactive fragments. Now, this angiotensin 2 is a very potent vasoconstrictor. So it causes vasoconstriction, which leads to rise in BP. It also causes sodium and water retention and aldosterone secretion. Now, how this is done? Firstly, its vasoconstriction action is mainly because of constriction of the arterioles that are present in the kidney. So in the kidney, it constricts the glomerular arterioles, mainly the afferent arterioles, and this results into rise in systemic arterial blood pressure. Now, angiotensin 2 also stimulates the release of vasopressin from the hypothalamus. And we know that vasopressin is ADH, that is antidiuretic hormone, and this will result into sodium and water retention. It will also cause concentration of the urine and also reduce its volume. And finally, it stimulates the adrenal cortex, which will lead to secretion of aldosterone. And this action is also shown by angiotensin 3, and this will result into increased blood volume. So there is increase in BP and increase in blood volume. So to sum it all together, first, renin release will occur because of low BP and low sodium excretion. This will act on angiotensinogen and convert it into angiotensin 1. This, in the presence of ACE, will get converted into angiotensin 2, then finally to angiotensin 3 and 4. Angiotensin 2 will cause vasoconstriction of the renal afferent arterioles, which will lead to increased peripheral resistance and ultimately blood pressure. And angiotensin 2 and angiotensin 3 both will cause increased aldosterone secretion, which will lead to sodium and fluid retention, increased cardiac output, and ultimately increase in blood pressure. Now, this is the classification of antihypertensive agents, antihypertensive drugs, sorry. Here we have diuretics, we have renin-angiotensin system inhibitors, and we have sympathetic inhibitors. And just now we saw about the renin-angiotensin system, and ACE inhibitor comes under this class. So in ACE inhibitors, we have all those drugs that end with the term pril. So you can easily remember the names of all these drugs. So they have pril term at the end. So we have captopril, enalapril, lisinopril, perindopril, ramipril, fosinopril, quinapril, and terendolapril. Okay, and the main drug that we'll be discussing today is enalapril. Then this is the structure of enalapril. So as you can see here, it has a benzene ring. It has an ester group also. C double bond OR is an ester group. So it has a ethoxy ester group because it is C double bond O C2H5. Then a ketone group is also present here, and a carboxylic acid group is also present. One heterocyclic ring is also present, which is this ring, and this is the pyrrolidine ring. So one benzene ring, pyrrolidine ring, one ester group, ketone group, and one carboxylic acid group is present. Also, enalapril is made up of two amino acids, and the two amino acids are L-alanine and L-proline. And this entire structure here, this is the structure of L-alanyl L-proline molecule. Okay, so you need to remember the name of these two amino acids also. Next is the SAR of enalapril. So the prototype of ACE inhibitor is captopril, which we know. Then all the ACE inhibitors, firstly, this is the general structure of all the ACE inhibitors. They have a zinc coordinating group or a zinc binding group, which is present here. So this zinc binding group mainly binds with either a sulfhydryl group or a carboxylate group or a phosphonate group. Okay, so we have a zinc coordinating group. Then this carboxylate group is very important. It forms ionic interaction with the arginine side that is present in the active site of all the ACE inhibitors. So this carboxylate group interacts with the arginine moiety that is present in the active site of the ACE inhibitors, and also a 6 to 7 carbon atom distance should be present between the carboxylate group and the zinc coordinating group. Then is enalapril is a prodrug. We all know what prodrugs are. So prodrugs are biologically inactive compounds, which when we take them after their administration in our body, they are metabolized and then the main active drug is produced. So enalapril is a prodrug in the liver. With the help of esterase enzyme, it gets de-esterified to form enalaprilate. So this is very important. So enalapril is a prodrug that gets de-esterified. In the structure we saw in the middle, there's an ester group. So that ester group gets de-esterified in the liver with the help of enzyme esterase, hepatic esterase enzyme, and enalaprilate is formed. And it requires activation by hydrolysis of its ethyl ester group to form enalaprilate. So as you can see here, this is the structure of enalapril, which has a ester group here. This, in the presence of this esterase enzyme, gets converted into enalaprilate, and this ester group gets hydrolyzed to this carboxylic acid group. Now, ACE inhibitors, we saw in the first flowchart that ACE enzyme, angiotensin converting enzyme, it splits angiotensin 1 to angiotensin 2. Okay, so ACE enzyme converts angiotensin 1 to angiotensin 2. But apart from splitting angiotensin 1, it also splits off other peptides also, like bradykinin and substance P. So this is very important. ACE enzyme splits off other peptides also, like bradykinin and substance P. That's why enalapril increases the plasma kinin levels, and it also potentiates the hypotensive action of exogenously administered bradykinin. And this will lead to increase in the level of kinins. And this is responsible for cough and angioedema. Cough and angioedema, that is mainly produced by taking ACE inhibitors. So cough and angioedema is one of the most important area that is shown by all the ACE inhibitors, and they also interfere with the degradation of substance P. Okay, so ACE, apart from splitting angiotensin 1, also splits bradykinin and substance P. This will lead to increased plasma kinin level, and this increased plasma kinin level is responsible for development of cough and angioedema, which is the main area of all the ACE inhibitors, and it also interferes with the degradation of substance P. Next, this table again I took from KDT, and this table shows us the comparative features of all the ACE inhibitors. So here we have captopril, enalapril, lisinopril, fosinopril, perindopril, and ramipril. So if we talk about the chemical nature, captopril has a sulfhydryl group. So this is the structure of captopril. As you can see here, this is the sulfhydryl group that is present, which is a unique molecule that is seen only in captopril. So its chemical nature is that it has a sulfhydryl group. Enalapril structure we just now saw, it also has a carboxylic group. Then lisinopril, in lisinopril also, this is the structure of lisinopril. Even this has a carboxyl group here, and one is present here. Next is fosinopril. Fosinopril has a phosphonate group. So phosphonate group is this. P double bond OOR is the phosphonate group that is present here in fosinopril. Next is perindopril. Perindopril, yeah. So in perindopril also a carboxyl group is present, which is this C double bond OH, and ester group is also present here. And lastly, we have ramipril. Even ramipril has a carboxyl group, which is this C double bond OH group is present here, and also this ester group is present. Now, if we talk about the activity status, this is very important. Out of all the ACE inhibitors, all are prodrugs except captopril and lisinopril. Captopril and lisinopril are directly given because they are directly active, but rest all drugs are given in the form of prodrugs. So enalapril will get converted into enalaprilate, fosinopril will get converted into fosinoprilate, then perindopril to perindoprilate, and ramipril to ramiprilate. Then if we talk about the bioavailability, maximum bioavailability is seen with captopril and minimum is with lisinopril. And if we talk about the mode of action, all the ACE inhibitors are excreted via renal route except fosinopril, which is excreted both via renal and hepatic route. So there's this exception here, so you need to remember this. Only fosinopril is excreted via both renal and hepatic route. So the four main points that we need to remember here are the chemical nature, their activity status, where captopril and lisinopril are not prodrugs, rest all are prodrugs. Bioavailability also you can remember, and also mode of excretion. Rest these time of action, elimination, T-half, and duration of action and daily dose is not that important. Next is the ADR part. So in ADR, first one is hypotension. So initially a sharp fall in BP occurs, and hypotension is mainly seen in all the patient because it is an antihypertensive drug. So excess use of enalapril can cause hypotension, and this is also mainly seen with those patients who are taking diuretics, or if we have a CHF patient. Next is hyperkalemia. So hyperkalemia is more likely to occur in those patients which have impaired renal function, or those patients who are taking potassium sparing diuretics or NSAIDs or beta blockers. Then we have cough and angioedema, which we discussed right now. So a persistent brassy cough occurs in around 4 to 16% of the patients, which is often reversible. And if that cough occurs, then it requires discontinuation of the drug, and it subsides after 4 to 6 days. That is, within 1 week it will subside, and it is not dose related. It is mainly caused by inhibition of bradykinin or substance P breakdown in the lungs of the patients. Next is rashes and urticaria. So this also occurs in around 5% of the patients. Then we have angioedema. So angioedema is basically swelling of the lips and the mouth, and also nose and larynx. So this develops within few days, and this is mainly because of airway obstruction. This can cause airway obstruction, and this angioedema can be prevented by giving the patient adrenaline or antihistaminics or corticosteroids. Then we have dysgeusia. So this is a new term here. So dysgeusia is actually a reversible loss or reversible alteration of taste sensation. Okay, and this dysgeusia is mainly seen with captopril. This is not seen with enalapril. So you need to remember this. So this is very important. Captopril is the ACE inhibitor that causes reversible loss or reversible alteration of taste sensation. Then we have fetopathic nature, which is basically teratogenic nature. So fetal growth retardation occurs, hypoplasia of the organs also occurs. Hypoplasia means in development or under development of all the organs, which will lead to fetal death. So this occurs if ACE inhibitors are given during the later half of the pregnancy. And there is higher malformation rate of fetuses that are exposed to ACE inhibitors during the first trimester. That's why ACE inhibitors are absolutely contraindicated in pregnant women. Then we have acute renal failure. So if ACE inhibitors are given to those patients who are already having bilateral renal artery stenosis, then this will lead to acute renal failure. That's why ACE inhibitors are contraindicated in such patients. And lastly, we have granulocytopenia and proteinuria. So granulocytopenia is decrease in the number of granulocytes, and proteinuria is presence of protein in the urine. So these are very rare ADR, but even these can occur, and these are mainly seen with people of renal disease. And if this occurs, then we need to stop the drug. Next, we have drug-drug interactions. So first is with diuretics. So diuretics will synergize the hypotensive action of ACE inhibitors. Okay, so ACE inhibitors these are antihypertensive drugs. So they were causing hypotension, but if the patient is also taking diuretics, then there will be synergize of the action of synergesis of the action of the hypotensive action. So which is mainly because of depletion of sodium and increase in in renin levels. So in diuretic treated patients, the starting dose of ACE inhibitor should always be low. Next is with NSAID. So indomethacin or any other NSAID will attenuate the hypotensive action. Okay, this is important. It will attenuate. Diuretics were causing synergesis with the hypotensive action, but NSAIDs will attenuate the hypotensive action. Attenuate means it will not cut, it will reverse the hypotensive action by retaining salt and water. So that's why incidents of renal failures have been reported when NSAID was given to a patient who was receiving ACE inhibitors plus diuretic. Next is with lithium. So ACE inhibitors will reduce the lithium clearance. Because of that, lithium won't be excreted from our body and the patient will be exposed to its toxicity. So lithium toxicity will occur. And lastly, hyperkalemia occurs in those patients who are taking ACE inhibitors, as well as there is concurrent administration of potassium supplements or potassium sparing diuretics. So it will cause hyperkalemia. So with diuretics, there is synergistic action that will cause more of the hypertension. Then with NSAIDs, they will attenuate the hypotensive action. Then with ACE inhibitors, they will cause lithium toxicity. And if potassium supplements and potassium sparing diuretics are given, then hyperkalemia will occur. Now this question came in GPAT 2012. The question was, the following ACE inhibitor is used in the treatment of CVS disorder and is synthesized from a natural amino acid, that is L-alanine and L-proline. So which is the drug? And the options were enalapril, ramipril, lisinopril, and captopril. So we discussed this in the initial slide. Enalapril is the answer here. That is made up of 2 amino acids, which are L-alanine and L-proline. Okay, so enalapril is a dipeptide that is made up of L-alanine and L-proline. Now you need to remember about these other ACE inhibitors also. Ramipril is the drug that contains amino acid L-alanine. It contains only alanine. Proline is not present here. Then in lisinopril, it contains L-lysine and L-proline. I'll underline this, L-lysine and L-proline. And finally, we have captopril that contains only proline. Okay, so enalapril contains L-proline and L-alanine. Ramipril contains only alanine. Lisino contains lysine and proline both. And captopril contains only proline. So you have to read the question carefully here. The question says, which ACE inhibitor contains both the amino acid, that is alanine and proline. Okay. So yeah, thank you. I hope you enjoyed this video, and please share it with all of your friends who are preparing for GPAT and NIPER. And please like this video and also subscribe to Dharmesh Mehta's YouTube channel, where we post such informative videos every day. Also, we have a free WhatsApp group where we post daily MCQs related to GPAT and NIPER. So if you are interested in joining the WhatsApp group, please drop a text on these two numbers that are given here, and we'll do the needful. Thank you.